From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Very much. This evening I want to talk a few minutes about hypercalcemia. Hypercalcemia is a very important clinical abnormality. It is most commonly caused by hyperparathyroidism and malignancy. And many of the patients start to excrete calcium in their urine before developing hypercalcemia. And many of the patients, if the calcium level is low, like less than 11, they develop mild hypercalcemia, and most often that is due to primary hyperparathyroidism. So mild hypercalcemia, think about primary hyperparathyroidism. But when the calcium level is very high, like more than 15, around 15, always think about malignancy. So primary hyperparathyroidism and malignancy, these are the two most common causes of hypercalcemia. And please never forget that, because almost all questions are concentrated on that. Now many patients develop chronic hypercalcemia, like they develop it over like 6 months. And some of them develop kidney stones. And that's just a benign condition. But when they develop a malignancy, they started to produce PTH-related proteins as part of paraneoplastic syndrome, and that causes their calcium to go high. So the neoplasm, if you look carefully in these patients with acute hypercalcemia, a severe hypercalcemia, you will find a neoplasm in these patients, and the prognosis, needless to say, is poor. And there are granulomatous diseases like sarcoidosis or tuberculosis or histoplasmosis. They also develop hypercalcemia. Sometimes patients take more calcium, or there is milk alkali syndrome. Some patients take vitamin D capsules excessively, vitamin A excessively. That also causes hypercalcemia. There are hormonal endocrine causes for hypercalcemia, like primary hyperparathyroidism, secondary hyperparathyroidism. These causes are some of the most common causes of hypercalcemia. You can also think about pheochromocytoma, thyrotoxicosis, when the body metabolism increases. So those are the endocrine causes. Acromegaly is another cause. Now tumor-related causes like cancers and multiple myeloma. You see, in multiple myeloma, the osteoclast activity increases, and there is so much calcium being reabsorbed from the bones and mixing in the blood that causes hypercalcemia. Thiazide diuretics. Never forget that, folks. Thiazide diuretics, they cause hypercalcemia. Paget's disease, and patients who are just immobilized, they develop hypercalcemia. And complications of kidney disease, transplantation, lithium intake, those are the other causes of hypercalcemia. And milk alkali syndrome, and it needs some mention. Recently it's increasing because calcium ingestion has increased in elderly patients for the prevention of osteoporosis. So these patients develop milk alkali syndrome very easily compared to others. Now, one important point, very, very important point is hypercalcemia causes nephrogenic diabetes insipidus. Okay, and don't forget that. Hypercalcemia causes nephrogenic diabetes insipidus. That's why these patients develop polyuria. They excrete large amounts of urine. And now let me talk a few minutes about signs and symptoms. You need to take a history and you should do physical examination carefully, and you should also think about duration and the level. Is it severe? Always think about malignancy, and some of them develop neurological problems. Look for neurological problems. In the mild cases, it's just asymptomatic. These patients don't develop the symptoms. In severe hypercalcemia, they develop, as the calcium goes higher, they develop conditions like constipation and polyuria, nausea, anorexia. Some of them, due to the deposition of calcium in the GI tract, develop peptic ulcers, and hematuria due to the damage of kidneys, polyuria, as I said, from nephrogenic diabetes insipidus. And what happens, as they lose more urine, they develop volume depletion and dehydration, and acute kidney injury because of dehydration. And neurological abnormalities like drowsiness, weakness, depression, lethargy, and if it is very severe, they go into coma. So, and also think about calcium role in the heart muscle. What happens due to hypercalcemia? On EKG, the QT interval gets shortened, and patients develop ventricular ectopies and arrhythmias. So severe hypercalcemia, whenever it is more than 15, always think about cancer. And also check their urine excretion of calcium. Whenever it is more than 200 mg per day, that suggests hypercalciuria. If it is less than 100, it suggests hypocalciuria. And whenever it is hypercalciuria, it suggests vitamin D therapy or malignancy. Whenever it is hypocalciuric hypercalcemia, that suggests other conditions like milk alkali syndrome or thiazide diuretics. You see, so check calcium in the blood level and check calcium in the urine level, and those two things, if you combine, actually you can arrive at your diagnosis. See for whether it is hypercalciuric hypercalcemia or hypocalciuric hypercalcemia. That makes tremendous difference to pinpoint the diagnosis. Now a few words about treatment. The most important thing is aggressive hydration. That's the most important. So when you see a patient with hypercalcemia, aggressively hydrate them and forcefully do calciuresis. And these patients develop hypovolemia due to polyuria caused by nephrogenic diabetes insipidus. That's why we should give them either normal saline or half normal saline rapidly, like 500 ml per hour. And you don't give them thiazide diuretics. As I said, thiazide diuretics, they cause hypercalcemia. So don't add insult to the injury. That's why you don't use thiazide diuretics in these patients. The drugs of choice are bisphosphonates. But bisphosphonates, they start being effective like 48 to 72 hours. Okay, so between before 48 hours, you can always use calcitonin. Okay, so you saw the hypocalcemia, go with calcitonin, and then go with bisphosphonates. So start bisphosphonates, but if you need an immediate action, go for calcitonin, because bisphosphonates start acting like 48 hours after you start them. So that's the most important points in the treatment. So bisphosphonates, aggressive hydration, and always look for malignancy, because severe hypercalcemia.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you. Are you preparing for USMLE? Please do not waste thousands of dollars on training courses. Get the books written by Dr. Paul with the student-to-student tips and memory aids. The success will be yours, and you will soon realize your dream of becoming a physician in the United States. If you are preparing for Step 2 clinical skills, study USMLE Smasher, a guide helping thousands of medical students to pass this examination. For more information, visit us at www.drpaul.org.